Wassila Taha.
It's my first time to be here in this magnificent city, and I would like to thank Dr. Hadzia Walischi. Dr. Hadzia, congratulations. I'm feminist, and I'm truly thrilled and very excited to see so smart and so dynamic lady on the head of the Department of Vascular Surgery here. And I'm really congratulations, Dr. Hadzia, and I wish you all the success. And thank you for the kind invitation. Thank you. هي مش دي. So I have been asked to cover the topic of IVUS. I have no disclosure for this topic. IVUS, it's the abbreviation of intravascular ultrasound. And this is our internal eye. Either we are vascular surgeons or vascular internists or interventional radiologists. This would allow us to see the vessel from inside. So from inside, it's very near to the wall, so we need a high frequency which range from 20 to 40 megahertz. And this is very important to see with no radiation and with no contrast. Well, it has a very big room with the cardiologist, interventional cardiologist, to see the plaque inside the coronary artery, and it gives them a very good idea about the vulnerability of the plaque. Either it's a stable plaque or it is a soft plaque or prone to embolize. What about in our field for the peripheral endovascular procedures? This is how it looks, the new era of the vascular lab, and the screen of the IVUS is embedded in the multiple screens during the inside the cath lab. It's very useful for the iliac vein stenting, either non-thrombotic or thrombotic lesions, for the aortic interventions, aortic dissection, for the EVAR, coarctation, the carotid atheroma evaluations, as well as for the peripheral arterial disease, mainly with the CTO. For the aorta here, it's a very interesting example. We have here the dissection, and it's very useful modality to see the folds and to differentiate between the folds and the true lumen. This is how it looks like. The catheter of the IVUS is the left renal vein, and the left renal artery arises from the false lumen. A lot of publications about the IVUS and in the thoracic aortic repair, but this is what in the multi-institutional, multi-central study, and including more than 2,000 patients. And the author, they conclude that independently, there was association with improved long-term survival in the patients with the IVUS. IVUS also, this is a good example because it gives us a very good idea about the landing zone of the left subclavian artery. Here we are. And also it correlates very well with the ultrasound photos with the dissection, the flap is very well seen by B mode as well as by the color flow. With the coarctation of the aorta also, it's a very good modality. It has a major play a major role to see the maximum coarctation and with the maximum extrinsic compression. Coming to the EVAR, and I see that there is a big activity to EVAR procedures here in Damiette hospitals. So IVUS, it can help also for the patients, vulnerable patients with the impaired kidney function test to minimize the contrast and to see the renal level, as well as if there is any endoleaks, very sensitive for these indications. And another important indication here with the incomplete stent graft expansion. So before the completion, we can see that the stent is not very well coapted with the walls. So another important indication to the use of IVUS. What about the carotid artery disease? As mentioned with the coronary arteries, it's also give a very good idea about the morphology of the plaque. And this is a histological, virtual histology. It gives the burden of the different elements of the plaque. Either it's a fibrous plaque or maybe heterogeneous mixture of the previous elements, or more than one element, fibrous or even fatty plaque. So it's prone to embolize. And according to the colors, for the green, it's a fibrous plaque. And for the yellow, it's fibrofatty. And for the red, it's the lipid core of the plaque. So there are two big studies, the Capital and the Victory, and they are assuming that the virtual histology to see the morphology and the burden of each element in the plaque prior any intervention, carotid intervention. And here we are inside the carotid, and here the distal. It's like from the distal till the maximum stenosis of the plaque. We can see there is red dots, and the red dots, it means there is a lipid core of this plaque introducing to the lumen itself and down to the proximal end of the artery. What about the peripheral artery system? This is a systematic review with the total number, high patients included, 2,000, and they show patency rate and the free from re-interventions with low amputation rate in favor with the patients guided during their interventions were guided by the IVUS. Also an important indication and a major role for the IVUS in peripheral arterial disease with the long CTO or chronic total occlusions. When we are facing long occlusions and the wire goes to the subintimal angioplasty, this is a very good indications for the IVUS to direct the re-entry catheter into the true lumen. IVUS in venous disease, in fact, it has a very important indications. Either we are dealing with non-thrombotic lesions or thrombotic occlusive lesions. And here, Professor Raju, he has shown that the IVUS appears to be superior to the single plane venography with a morphological diagnosis of iliac venous outflow obstruction, and it's really a precious assistance tool for the accurate placement of the venous stent. And he mentioned in one of his esteemed and distinguished publications that third to half of the cases can be missed with the multiplanar venography. And here in the systematic review, Professor Peter Neglen mentioned that there is superiority of the IVUS imaging over the venography for diagnosis, as well as the IVUS guidance one more time for the proper stent deployment. A video trial by Paul Gagne, it's a multi-center trial from USA and 3 centers from Europe, including 100 patients with advanced clinical manifestations and with occlusive iliac disease. And they are submitted to venography and IVUS. IVUS was succeed to identify 81 out of the 100, while the venography 51 out of the 100 patients with statistically significant p-value. So why you are using IVUS in the venous disease? I would like to share with you 2 cases. One non-thrombotic with the May-Turner syndrome, and as always, as all we know, it's the compression of the left common iliac vein by the right common iliac artery. And this is a female patient and with left lower limb edema, heaviness, and left lower limb edema up to the groin. CT venography, the report was there was no significant compression of the vein. And we did repeat the duplex showing a tight proximal common iliac vein, even with collaterals. Here the CT venography, for the radiologist, they mentioned that this is quite normal to see the proximal end of the left common iliac vein compressed by the right common iliac artery. And one more time, we like here the hemodynamic impact which is provided very thoroughly by the duplex. So this is the duplex of the patients, tight stenosis of the left common iliac vein compressed by the right common iliac artery. Not only this, also with some collaterals around this tight stenosis. Here we are with the venography as well as with her IVUS. We can see here at this moment, yes, at this moment there is the tight, really the tight caliber of the proximal left common iliac vein. And we decided to stent this segment, and this is by venography prior to the stenting and with the correlation of the image with the IVUS. Here the cross-section of the IVUS starting showing the most tight stenotic area and the outflow and the inflow before and after or proximal and distal to the lesion. And this is the one other beauty of the IVUS because there is a mark, and when we pull back, you can really accurately also calculate the length of the lesion. Here we are, the deployment of the stent, and this is the completion of the venography with the free flow up to the IVC, and this is the control with the duplex showing by B mode well-deployed stent covering the left common iliac vein segment as well as by the confirmed by the color flow. The second case is non-thrombotic lesions with the bilateral C6 and high quality of duplex. It's not only the reflux count, but also we have to think the proximal obstruction and to go above the inguinal ligament to see the iliac veins. And here we are, we have a very retracted left common iliac vein and with the collaterals also around the stenotic area. Here we are with the venography, very correlated and corresponding to the duplex. We have on the left side a thread-like flow with the bunch of collaterals. And the IBC in this case was totally free. And this is a patient suffering from bilateral post-thrombotic limb. This is the right side and very correlating, well correlating with the duplex ultrasound. It showed the double flow with the external iliac vein as well as the bunches of the collateral. And this is the IVUS of this patient's prior stenting. We can see at this level the lot of synechia and lot of remnant, the echogenic lines around the catheter. This is the remnant of the old thrombi. And this is the pre-stenting ballooning, short high pressure balloon. And this is the deployment of the stent and with multiple significant stenotic lesion. So this is the post-stenting dilatation. And this is the completion of the venography as well as completion. This is one more advantage of the IVUS. So the post-stenting scanning with the IVUS, we can see a very quite patent iliac vein with no more remnants. And also the completion or the control by the duplex follow-up by B mode and by color flow, showing the patency of the stent. To conclude, yes, IVUS has a lot of advantages, but it also has its limitations. The advantages, as mentioned, in the aorta, in the plaque morphology of the carotid, and it's an invaluable tool for the venous disease, mainly if you are planning for stenting, but it has its own limitations, the expenses. Of course, it's an expensive tool and lack of scales, and as mentioned before, it has no hemodynamic information that is provided by the duplex, and in fact, it's an invasive technique. I would like to invite all of you, don't miss please, it's a Zoom, it's an online Saturday, بعد بكرة على طول at 6 p.m. Cairo time, and this is a collaboration with our society IVLA. Our here, it's ours, it's all the vascular community in Egypt. IVLA, it's all about all of us. And in collaboration with the American Venous Forum, and this is like a journal club, so the highly selected papers and will be discussed and presented by the principal authors of themselves. Saturday, 29th April at 6 p.m. And don't miss, please, this is in person, our annual meeting. It will be in Cairo. Save the date, 15th and 16th June 2023. And thank you so much for your attention.